My name is Carla Nester, and I'm an adult and pediatric nephrologist at the University of Iowa in the Stead Family Children's Hospital. So, the major part of my clinical work is actually with the glomerular diseases. The question about how are C3 glomerulopathy and immune complex MPGN related, and that's a tough question actually, except for to say that they are both complement-mediated kidney diseases. For instance, with C3 glomerulopathy, we actually have some very nice animal models that tell us that, when C3 is deposited on the kidney, it is very likely to do with alternative pathway dysregulation, et cetera, et cetera. So we have some fairly good background to tell us what C3G is. Primary immune complex MPGN gets a little bit more complicated. And here's one of the first reasons is because many of these primary immune complex MPGN patients are actually C3G patients that are just presenting differently because of an intercurrent illness, if you will, meaning they present as immune complex MPGN, but then when they settle down from whatever the infection was, you go on and if you happen to biopsy them 6 months later or something like that, now they're C3G patients. So that's one reason why they are related, the two diseases. The second thing is that there's actually been some decent publications out of a French group, for instance, that said that the immune complex MPGN patients are just as likely to have the presence of the complement dysregulating drivers as C3G is. So again, the drivers of the disease for immune complex MPGN are very similar to the drivers of disease of C3G. So again, they end up being cousins that way in terms of exactly what the disease is. Both diseases are classic glomerular diseases, if you will. And so a patient may, in fact, present asymptomatically and they're in for a routine physical exam, and somebody discovers that they either have high blood pressure or blood in the urine, and very frequently high-grade urine protein. Now, that's an incidental finding, but very many patients also present with the more aggressive glomerular disease findings, which for the patient, they notice that they're swollen everywhere. That their legs are, twice their usual size, or their face when they wake up in the morning is swollen. And then someone in the process of working them up discovers that they have high blood pressure, an elevated creatinine, and this really high urine protein. So there's quite a bit of range, if you will. I've even had patients present within months of already being close to end stage, if you will. So they can get quite poor kidney function before they even get identified. But it truly is usually presenting as a classical glomerular disease. And those signs that I mentioned to you are really what your clinician will see. And maybe your patient will see some of those. Can be picked up incidentally, like I said, in a routine pediatric physical, sports physical, that sort of thing. But more likely what moms and dads are going to see is when their child goes pee, they say, oh, wow, why does that urine look like Coca-Cola? And that's the phrase that they will actually use, tea colored or Coca-Cola colored. So they've got gross hematuria they may see in the urine, or they may say, now all of a sudden my child's shoes don't fit because their feet are so puffy that they don't, their feet don't fit in their shoes anymore, or their belt doesn't go around their waist anymore, or they again notice their face is swollen. And frankly, very frequently, because people are not expecting kidney disease in children, often it's suspected to be allergy. That they might have a little bit of allergy. But if you really look closely, allergy is swelling around the eyes because the eyes are irritated. Glomerular disease patients are swollen everywhere. It's not just the eyes usually. But anyway, they can prevent what you think is going to be a fairly benign disease, but then it ends up being something much, much more significant, frankly. So if we think a little bit more precisely about the underlying mechanism of disease for C3G and some of those immune complex MPGN patients, it really is dysregulation of the alternative pathway of complement. And when you think about the alternative pathway of complement, you think about the cause in most humans is either number one, genetic, and that's probably only about 20% of patients, but it's in one of two proteins, the C3 or the factor B, or maybe factor H. So there's a few genetic abnormalities that may actually trigger the disease. But then there is also autoimmunity. And the autoimmunity is this unusual or abnormal protein. You shouldn't be making it, but it's autoimmune. You are making it. It actually attaches to what we call the convertases of the alternative pathway of complement. So that background's a little bit, it's actually very important, because now let's skip forward and we think about Empaveli. Guess what Empaveli binds and blocks? It happens to bind C3, which is the major protein of the convertase. And it's one of the major gene abnormalities that is found in C3G to cause the problem. So what we would have had suggestions of from the animal models is that if you bind that convertase and you block its function by blocking the ability of C3, this is where Empaveli binds, is to C3 and particularly C3b. But by binding C3 and C3b, you basically stop the activity of those convertases. And by doing that, you actually are able to stop the activity of the alternative pathway. So stopping the alternative pathway activity should, in theory, stop disease activity. I've spent a good bit of time saying that the alternative pathway is up here, right? Well, and then there, of course, is a terminal pathway. Of course, there's classical pathway, lectin pathway, etc. But what happens to physicians who are not as used to working with the complement pathway is they say, you know what, I'm going to block the terminal pathway in this disease. And in fact, they could do that because there is prior to 2025, it was one of the only complement inhibitors that was available. But if you were listening and you understood that the alternative pathway is the source of the disease here, blocking the terminal pathway is blocking too far downstream. So you are still allowing the convertases to work and still chew through the pathway, still eat up all the C3, et cetera. So really, at the end of the day, blocking the terminal pathway is not going to be completely, it does actually help in some degree because it's a great anti-inflammation approach, frankly. But if someone has a very active convertase because of a gene abnormality or because of an autoimmune protein, then that's going to just keep going right through that terminal complement blockade. So at the end of the day, you do really kind of need to know what the complement system is and what's the difference between the alternative pathway, the terminal pathway, the classical pathway, et cetera. It kind of does make a difference. One final comment, though. It just so happens that the alternative pathway is the amplification loop for all three pathways, lectin, classical, and alternative. It's the amplification. So the classical pathway feeds into the alternative pathway. The lectin pathway feeds into the alternative pathway. So again, that's what gives AP blockade or alternative pathway blockade so much power, is because you're blocking the central amplification loop of all three pathways, actually. So the trial of pegcetacoplan was actually a 6-month trial or a 26-week trial. It was placebo controlled. So half of the patients will have gotten exposed to placebo, half of them exposed to pegcetacoplan, which was a subcutaneous infusion given 2 days a week. So Monday, Thursday, or Tuesday, Saturday, that sort of thing. Anyway, it was a 26-week trial, and probably important to mention here, because this has been the only time that this has been done, where you have native kidney disease, you have transplant kidney disease, and you have pediatric patients down to the age of 12, and you have adult patients. So this is the only time you've seen that in a phase 3 reported out yet. There are other studies going on that are going to accomplish some of this, but right now this is the first one to report it out for those 4 different populations, 26 weeks, either placebo or treatment. So that's the background. By the way, that same group of patients, many of them have been followed out to 52 weeks now and even further. So there is even more data. But the thing that actually earned pegcetacoplan their FDA approval is the 26-week data. And really, driven by primarily their primary endpoint, which was proteinuria reduction. And, from a clinician standpoint, we really do, and there's a couple of decent natural history studies that have also supported this, but even clinicians have really strongly felt that if you could reduce the urine protein, you could reduce the risk for loss of kidney function. So hopefully that makes sense. But in the Pegcetacoplan study, by the time, or the VALIANT study, by the time they got to 26 weeks, the treated group, so the ones that were exposed to the pegcetacoplan, had a 68% reduction in their urine protein as compared to placebo. So again, this should be a very important finding because there's radar data, there's glossin data, there's a number of different pieces of data that would suggest that if you can reduce the urine protein by this degree, you really have altered the risk for kidney failure or altered the risk of or the slope of the loss of GFR, if you will. That was the primary endpoint, and that was the one that was the most significant for the group. But there were two other endpoints that I think are worth mentioning. The next one is GFR, estimated glomerular filtration. Again, I'm going to talk in terms of comparison to the placebo group. They actually saw a 6.3 milliliters per minute per 1.73 meters squared improvement in the GFR in the pegcetacoplan group as compared to the placebo group. And again, I hadn't shared yet, but these patients, we think without better treatment, were going to end stage just regularly, just relentlessly going to end stage for many patients. So that 50% of patients or more were losing their kidney within 10 years of presentation. So that means their GFR is dropping and dropping and dropping and dropping, right? Otherwise, they wouldn't be getting to end stage. But in fact, with the pegcetacoplan study or the VALIANT study, what they saw compared to placebo, that they actually had an improvement in the GFR, which is incredibly important from a clinician standpoint if we're going to rely on those natural history studies, right? And then I think that the final endpoint that I would like to mention is this one about C3 deposition. It turns out that you diagnose this disease by doing a biopsy and seeing C3 deposited on the biopsy, and then you find out that they've got complement dysregulation, and that's how you make the diagnosis. But the definition is 2+ of C3 over any other immune reactant is the official definition. But really what I want to do is skip to the point of one of the endpoints, exploratory endpoints in this particular study was that 71% of the patients actually saw a resolution of or a clearance of that C3 deposition on the biopsy. So the reason that this is what we could have predicted from the animal models, but the reason that's so important is because if I see that patient now, I wouldn't even be able to diagnose them with C3G, right? So, because they've cleared off. And that feels to us like that's an incredibly important event to happen. Now, our regulatory agencies don't accept that as a surrogate outcome, et cetera, but it's very satisfying to see the combination of improvement in urine protein, improvement in GFR, and then what appears to be resolution of the C3 deposition on the biopsy. Just the only thing that often people will ask me is that if you're blocking the alternative pathway and it turns out it's an incredibly part of your immune system, are we setting these patients up, for significant adverse events or infections, et cetera. And I think it's probably worth sharing with your listeners that we worried. Actually, even when we first started using complement inhibitors, we worried that patients were going to get at risk, at least, for overwhelming infection or at risk for things that we were not going to appreciate, that it wasn't going to be quite as bright and shiny as it looks like it is today. But in fact, in this 26-week trial, well, I didn't say that it's encapsulated organisms that we're really worried about. And in fact, in the 26-week trial, they didn't see any encapsulated organisms, so infections in the patient. So the real point I wanted to get to here is that if the physicians are paying attention and they actually immunize or vaccinate their patients appropriately, watch them if they get an intercurrent illness and make sure that we do a blood culture if we need to, it turns out we're going to probably get away with using these drugs really much more safely. Or I'm going to even go out on a limb and say quite much more safely than we ever thought. And it's going to be very satisfying, I think. We honestly don't know, but I will tell you, what we tell ourselves in the science field is that, first of all, the kidney sees a lot of your blood supply, much more of your blood supply practically than any other part of your body, right? Of course, except for the heart, right? But so it's possible that the kidney just sees so much more of your blood supply, and it's under pressure, not under pressure, et cetera, that there are different dynamics that may trigger the complement slightly differently. That might be number one. The second thing is that the regulators of the complement system may be different. I won't say that they're malfunctioning because I don't know that, but they just may be different. And then the third thing I will say is that people have used the term zip code. The kidney is just the right zip code to have a lot of complement dysregulation happening. And what they really mean by that is there's a protective layer over your endothelium in the kidney called the glycomatrix. And maybe some individuals' glycomatrix is just a little bit more sensitive to the complement dysregulation that happens. That glycomatrix is at the kidney. It's not the same glycomatrix that's in the heart or that's in the pancreas, et cetera. So it's possible that there's just something about that zip code, if you will, that makes it more sensitive to the dysregulation of the complement system. But we don't technically know the answer. So that those are just suppositions that we're all making.